Welcome, everybody. It's my pleasure to announce this week's series of PCR webinars, which is entitled TAVI for Today and Tomorrow, What Matters the Most to Patients. And I'm privileged to welcome you all, and also I would like to introduce you into today's objectives, which are to illustrate through case in point and the latest data how new generation TAVI technology would optimize the full spectrum of lifetime management to our patients. Further, to understand what patients care the most in their TAVI journey, from first valve choice, durability, to minimizing patient reintervention. And finally, to discuss the latest definition and recent clinical data evaluating valve performance. And I can tell you that we have an outstanding faculty today. We have international well-renowned experts in the field. First of all, Rebecca Hahn from New York City, United States. We have Kentaro Hayashida from Tokyo, Japan. And we have Simon Redwood from London, United Kingdom. And in order to facilitate the discussion, I would like to ask Simon Redwood to present a recorded case first, which will enable us to discuss the key topics of lifetime management. So let me introduce you first to the key topic of lifetime management. We all know that we've come a long way from the very beginning of TAVI, when Alain Cribier implanted the first transcatheter heart valve, until today, where we discuss options to perform TAVI procedures in younger and lower risk patients. It's also clear that TAVI is more than just performing a principally feasible procedure where it is our main objective to bring the patient safely off the table, but rather to consider a number of highly relevant factors that eventually will impact on patients' clinical course through life. In this regard, the term lifetime management was coined and refers to the consideration of highly relevant factors during planning of the first procedure, allowing for future treatment options, but also considering durability and sustainability of our procedures. Now, I've listed some of these relevant factors on this slide, which we will not be able to go through for the sake of time through all of them, but we will try to cover the most relevant aspects in the series of PCR webinars. And without further ado, I would now like to ask Simon Redwood to present his first boxed case to facilitate the discussion.
Thank you very much, Michael. So I'm going to present a lady. She's aged 82. She's got severe aortic stenosis. She's very symptomatic, with both shortness of breath and angina, both CCS class 3 and NYHA class 3. And she's got a very unfortunate background history, medical history. She's got multiple medical problems in the past. She has myelodysplasia, for which she requires erythropoietin and frequent transfusions, and as a result of that has developed some antibodies in her blood, which makes transfusion very difficult. She's got an element of chronic kidney disease, but actually her GFR is not that bad. She had a hemicolectomy many years ago for ischemic valve, and then you can see there she has a multiple other comorbidities, including multiple joint replacements, and she's still awaiting a left ankle replacement. And you see there on the right-hand side the list of her medications, which I won't go through, but just to mention, she's only on a single antiplatelet agent, which is aspirin. You see here, resting ECG is really within normal limits, normal QRS, normal PR interval. And you can see here some snapshots of her resting transthoracic echo pre-procedure. She has significant aortic stenosis, and I will show you the gradients in just a minute. Here's the Doppler on the left-hand side, showing an element of aortic regurgitation as well. And left ventricular function is well preserved with no regional wall motion abnormalities. The estimated ejection fraction is 62%. And here you see her gradient, pre-procedure, peak gradient of 67 with a mean gradient of 48. So I think undoubtedly significant aortic stenosis with an estimated valve area in the region of 0.9. We performed a pre-TAVI CT scan, and you'll see here that her annulus area is 422 with an average diameter of 23.2, and the sinuses are reasonable size in the region of 26 millimeters with an STJ of 26 by 24. Both coronary heights are of adequate height, the left coronary being 15, the right just under 14. And she has good transfemoral access, excuse me, with both femorals in the region of 7 millimeters, no significant stenoses, no significant calcification. Oh, okay. So we discussed her in our MDT, and we felt that in view of her age and multiple comorbidity and her limited mobility with the multiple joint replacements, that she was quite high risk for a surgical ABR. She'd probably have a prolonged recovery. She was technically suitable for a transfemoral TAVI procedure, and the consensus was that that was probably the best for her. So my plan was to perform a right transfemoral TAVI with a 23 millimeter Sapien Ultra Resilia valve. And I'll just show a few brief pictures of the procedure. So this is the first setup shot. We now perform the vast majority of our Edwards Sapien procedures as single access. We find a good three-cusp view based on the CT, which you see here. We first introduce a pigtail and take a setup shot, have a very close look at the pattern of calcification, so we can decide where we're going to deliver the valve. And here is the Sapien Ultra Resilia 23 millimeter, which is placed across the annulus. You can see the calcification there just in the middle. And that was where we plan to implant the valve. Then using rapid pacing, using the Safari wire, we implanted the valve. As is routine for us now, we do 2 inflations. We feel that that provides a better hemodynamic result rather than just a single inflation. And following that, we exchange back to the pigtail and perform a root aortogram, which, as you'll see there, shows no significant aortic regurgitation and patent coronaries. A post-procedure echo confirmed a well-seated valve, again with no aortic regurgitation. And you'll see there the peak gradient was 13 with a mean gradient of 7. And finally, her ECG is unchanged. So just a brief overview of a 23 millimeter Sapien Ultra Resilia valve in an 83-year-old lady. Thank you very much.
Thank you, Simon. I think this is a very interesting case. Thanks for sharing this. First of all, of course, let me ask you, I've seen you performing the single access TAVI procedures during PCR London valves, and I was quite impressed. Can you, take us with you basically? When are you doing these procedures? What are the considerations? Can you do these procedures also with self-expanding valves? Is it mostly preferable for balloon expandable valves? Please explain us a little more about this.
So very good question. So we first did this about 4 or 5 years ago when we had a patient that had a functioning renal transplant, right iliac renal transplant. So we only had a single access from the leg. There was a fistula in one arm, and we wished to use cerebral protection from the right radial. So we really only had one access site. And we thought we would try this and see whether it worked, and it worked very well. It was very straightforward. And we've now transitioned to do virtually all of our Sapien balloon expandable valves using single access. The only times we won't are with bicuspid valves, where the anatomy is quite distorted and we like to have a pigtail to ensure we're implanting the valve in the right position. We haven't transitioned to self-expanding valves yet, and I think you really do need a pigtail sitting in the base of the non-coronary sinus to implant those accurately. But our routine, probably for over 95% of cases of the Sapien valve, is single access.
Great, thanks for answering. Also, I want to encourage the audience quickly to really use the chance of chatting with us. Please pose your questions. I'll try or will try to cover most of these questions during the course of this webinar. Simon, this was a very interesting presentation of an 82-year-old. What were the specific considerations you had when choosing a Sapien Ultra Resilia in this specific case?
Well, I think there are several. There's the first, there's a lot of big talk recently about females undergoing TAVI and also patients with small annuli. So she had both. She's female obviously, and she was going to be a 23 millimeter valve. And she was very clear to me that she didn't really want to have a repeat procedure in the future. In the UK, her life expectancy at the age of 82 is approximately 10 years. And so with a 23 millimeter valve, it is not likely, but it's quite possible that she would require a repeat procedure in the future. And now with the Sapien Ultra Resilia, we have shown lower gradients, specifically with small valves, but actually across the board with the Sapien Ultra Resilia, a better EOA. And if the surgical data is going to be replicated in the TAVI data, then a much lower likelihood of a repeat procedure.
Thanks. I think Becky Hahn has a comment. You want to make a comment at this stage?
Yeah, I just wanted to say, just a back of the napkin kind of calculation from all your numbers, Simon, also translated to a valve area that was extremely good for a small valve. So usually our stroke volumes don't change that much immediately after a valve goes in. And your stroke volume is very high because in women, we tend to see really increased ejection fraction, and as you showed, tend to have small ventricles. And so in this case, the stroke volume at baseline was about 90 cc's, which is very high. And then if you use that to calculate the valve area afterwards, it's extraordinary. You probably have a valve area of over 2 centimeters squared. And I think that that's something really to think about when we're using these new valves. The Sapien 3 Resilia is Ultra Resilia is just we've also found the same thing with tremendously large valve areas, even in the small valves.
And perhaps I could show this slide, which is actually from you, Becky, that probably highlights that. You can see from the two pictures in the bottom and the middle that you get a much bigger EOA with the Sapien Ultra Resilia, particularly with the small valves, because of the way the leaflets have been mounted on the frame. They're suspended in a different way, which improves the opening and improves the EOA. But actually, across the board, the EOA is seen to be bigger, even in the absence of the change in how they suspend the valve. So in the 26 and 29, which is probably a feature of the tissue and the way it's been prepared. And I know that you and Kentaro are going to talk a bit more detail about that in a few minutes' time.
Yep. So Simon, there's one question. Obviously, you impressed the audience with your single access TAVI procedures, and I think you've explained it partly, but you may want to address it once more. There's a question coming from Andrea Mariani. She says, with single access TAVI, how do you position correctly the valve without contrast injection to see the nadir of the non-coronary cusp?
Yeah, so I obviously went through that very quickly, but we find a very good three-cusp view. If necessary, we'll do 2 or 3 aortograms until we're very happy we're seeing the annulus side on, and carefully look at the aortogram that we perform and look at the pattern of calcification, the distribution in relation to the nadir of the cusps, and then use that as our guide to implant the valve. So what we will do is we'll introduce the valve across the annulus. We'll we'll acquire an image, and then we'll go back and compare it with the aortogram, and if necessary, go backwards and forwards 3 or 4 times until we are happy it's in the correct position, and then implant the valve. And actually, it's worked very well, and we have published it. We didn't have it wasn't randomized, but with historical comparison, we showed that there was no increased risk of aortic regurgitation. There were quicker procedures, there was less contrast, there was less radiation, and there were fewer vascular complications, because historically we often found that it was the non-access site where there was a vascular complication. We pay so much attention to the access site where we put the big sheath in, and then just ignore the other side, and that's the side that we often get problems. So it's quite nice to avoid that and just have single access.
Yeah, I can fully concur. I mean, many centers switch to doing radial approach for the pigtail, but this is an even nicer way of doing it, especially when you have nice opacification of the calcium, I guess. There's two additional questions, maybe slightly off target, but still quite interesting. Maybe we can try to tackle them. It's asked about the association of an SLG2 inhibitor for the management of associated heart failure. If this can improve the durability of TAVI. I know it's not easy by reducing myocardial inflammation. Does anybody know any information or can try to tackle this question?
I honestly don't know the answer to that. Very interesting concept. It would be really nice if we could show that, but I don't know. I mean, they do improve long-term outcome, but whether they're related to durability, we don't know.
I agree. We don't have the data at this point in time. And then a short question: is there evidence for TAVI in rheumatic aortic stenosis? Becky, do you have an answer on that one?
No, I mean, I'm sure that some of the valves that some of the patients that were included in the trials may have had rheumatic disease, but I don't know that we separated them out morphologically. So my guess is that, you know, you're able to, with a balloon expandable valve, to break the commissural fusion that occurs in a rheumatic heart, and that we did treat some of those likely in the partner trials. But I don't know exactly the number.
All right, thank you very much. I think we've answered the questions that came in so far. And with that, I would suppose that we take over and give the podium to Becky Hahn, who will present on contemporary view on valve performance, deep dive on VARC3 and the latest data. Becky, please take it from here.
Thank you so much, Michael. Thank you. I wanted to start with trying to understand some of the differences that we've all heard about between echocardiographic and invasive gradients, and I think it stems from a number of issues related to pitfalls of the way that echo versus invasive catheter measures gradients. And so when we see that there's laminar flow, which is what we end up having with a normal valve, there's a parabolic flow pattern within a tube, and then echo will measure the peak velocities. They can't average the slower blood flow along the sides of the tube. But when the flow becomes turbulent, such as with structural valve deterioration or with native aortic valve stenosis, that flow pattern becomes flat, and therefore the velocities across the entire tube are roughly the same. And so when we measure with echocardiographic gradients, we know that with laminar flow, then echo will measure the peak velocities, and therefore the catheter will end up measuring an average velocity. And so that's one of the main differences that we know occurs, and it's related to normal flow within a laminar flow within a tube. Now, we also know that there's a contraction coefficient when flow crosses a narrowed orifice. And so in a situation where you have an abrupt change in the size of the orifice, then we know that there is a continued narrowing of the flow distal to the anatomic orifice. And this is what we end up seeing as a difference between the vena contracta area and the anatomic area, versus when you have a more gradual entrance to, let's say, the leaflets, then you may not see any contraction coefficient. And so when we think about that in terms of valve design, we know that the gradual tapering of the valve of a supraannular valve, for instance, might mean that there is no contraction coefficient, and therefore the area that ends up being measured might be larger than in a valve, for instance, a lower profile valve, where we end up having a more acute change from LV outflow tract to across the leaflets. And so this is something else to really strongly consider when we're thinking about valve design and the geometry of the orifice that we're measuring. Now, the other thing that we have to deal with echocardiography is the fact that we can't really measure directly pressure recovery, which is what catheters can do. They'll measure, obviously, the pressure proximal to an orifice and then distal to the orifice, typically in the aorta after pressure recovery. And the pressure recovery may be greatest in those patients that have a smaller ascending aorta, such as smaller patients. And then the larger orifice area sizes and versus the ratio to the cross-sectional area. In addition, those non-eccentric jets, such as in a normal prosthesis, might actually also determine greater pressure recovery. Now, what we know when we think about the valve design then is that there's significant differences in the way that the blood flows across those valves. And what we've learned from pulsatile models, and this is again valves implanted into pulse duplicators, is that there's greater pressure recovery likely in the sapien valves and somewhat related to perhaps turbulence that occurs and platelet activation that occurs with the taller self-expanding valves. And then in addition, when you're measuring millimeter by millimeter the flow and therefore gradients across each of these valves, there's a pre-valve gradient that's higher in the sapien valve than in a self-expanding valve. And so together, you would end up seeing a higher gradient measured by cath, but also by echo in the two different valve types. And this is all related to, again, the construct of the valves. And what's been shown then when comparing both invasive and echocardiographic gradients across these two different types of valves is that we know that there's no difference, net difference in the cath gradient between the self-expanding and the balloon expandable valve, whether they're small or large valves. But there's a higher echo gradient when you're looking at the small versus the large valve, particularly in the balloon expandable valve. And that when you look at the echo cath differences, again, those differences between the echo gradients, which are higher, and the cath gradients, which are lower, are greater in the smaller valves for the balloon expandable valve. So again, no significant difference between self-expanding and balloon expandable in this particular clinical study, but indeed a great difference in the cath versus the echo gradients. Now, the same group went further to again look at specifically differences between the two different valve types and the catheterization, the invasive gradients. And they found that in a normal balloon expandable valve, it was independently associated with an elevated discharge echocardiographic gradient, but a significantly lower invasive mean gradient. So this is immediately after valve deployment, normal valve that has a higher echo gradient, but a significantly lower cath gradient, invasive gradient in the balloon expandable valve. And so important message to remember when we're doing comparisons of normative data. Now, the same group showed that as you have structural valve dysfunction, and as in addition in those patients with native aortic stenosis, that the cath and the echo gradients start to correlate extremely well. So we know that we can follow up our patients with echocardiographic measures. Now, so how do we define then dysfunction of the valve? Well, the ESC/EACTS definition from 2017 named or listed as moderate and severe absolute gradients. Now, these absolute gradients were based on the guidelines by echo that suggested cutoffs perhaps for possible aortic prosthetic valve stenosis. And the problem with that is that we know that these gradients are dependent on flow. They're dependent on ejection fraction, flow, and a variety of other measures. Now, importantly, this document also emphasized the fact that structural valve deterioration should include permanent intrinsic changes of the valve. And so we always start, obviously, with an abnormal looking valve before we try to determine whether or not there's been actual change in valve function over time. Now, this paper was important in showing that it was a retrospective analysis, but the impact of gradients on mortality after TAVR is not linear and is extremely complex, suggesting that there might be a lower gradient at which, not a high gradient, but a lower gradient, which may determine outcomes. And indeed, the relationship of cath versus echo outcomes was extremely difficult. So it's different. And so it's very a very complex relationship. Now that complex relationship was further defined, and this is a paper that was just accepted for publication in JACC Interventions, showed that the lower post-TAVR mean gradients was associated with worse outcomes. And that's because lower post-TAVR mean gradients was also associated with lower stroke volume, so lower stroke volume index, low flow, low ejection fraction. And in fact, when they looked at predictors of outcomes, it was not only the very low gradients that predicted outcomes, but as you can see here, the more important predictors were the ones that we've already known about, which is obviously paravalvular regurgitation. So it's important to really keep these things in mind, and put gradients into perspective. Now, another definition of structural valve dysfunction and deterioration was proposed by the VIVID working group, and the VIVID registry obviously looked at patients with structural valve deterioration and ended up getting valve-in-valve devices. And so they defined, again, stage 1 as having abnormal leaflet configurations without abnormal hemodynamics. But stage 2 was the abnormal leaflet configuration with changes in the gradient and the effective orifice area and Doppler velocity index, and then severe, even greater changes in mean gradients and EOA and DVI. And so this VIVID registry definition came very close to the current VARC document. And in that setting has been validated in a number of different ways. And so in the NOTION 8-year results, you can see that when using the ESC-EACTS definition, there was a significant difference in structural valve deterioration between surgical and transcatheter valves. And this was obviously the NOTION trial used self-expanding valves. But when you applied the VIVID definition, again, very close to the VARC-3 definitions, you see that there's no difference in structural valve dysfunction. And so applying those definitions, which involved a change from baseline, is important because we know that the obviously end result of the NOTION trial showed that there was no difference in mortality or heart outcomes between surgical and transcatheter valves. Now, the definitions can be further validated in some of these other studies that looked at the importance of morphologic changes. And so this is a study that looked at leaflet calcification as a predictor of outcomes, and that's a stage 1. And indeed, there was a hazard ratio of 2.6 in patients that just had leaflet calcification. And obviously, this was a hazard ratio of a 5-year outcome. And then obviously, as you developed hemodynamic valve dysfunction, again, this study showed that those were important in outcomes. And so we know it's change in hemodynamics that end up predicting outcomes. And that was also shown in this study that looked at the rate of change in hemodynamic valve deterioration that ended up predicting outcomes as well. So it is indeed the change in hemodynamics that's important rather than the absolute gradient. So follow-up by echo is prognostically important, and indeed it's the change that we're looking for. Now, how did the VARC-3 come up with their definitions? Well, it was derived from the comprehensive echo assessment of normative data from both the self-expanding and the balloon expandable valves. And what we noticed was that the absolute measurement, and these were 2 different core labs, the absolute measurement of valve area, mean gradients, and DVI were different, but the standard deviation as a percent of the mean were about the same. And so this is where we came up, because each of the iterations was different in absolute valve area, but the standard deviation from the mean was about the same. We ended up using percent changes of EOA and DVI in the VARC document to document a real change in function. And that made sense to us, because if you're going to have differences in valve construct and differences in valve hemodynamics, then it makes absolute sense that we need to use a percentage of the baseline in order to detect a change. And that's indeed, this was proposed by the normative data manuscript and indeed adopted by the VARC-3 document. And importantly, It was the mean gradient change of 20 millimeters of mercury, not an absolute 20, that was substantiated with outcomes in the Partner 1 trial. And so we do have data that supports the final definitions that were adopted by the VARC3 consortium, remembering that the VARC3 consortium was intended to improve the process scientific rigor and standardization of clinical research in valve heart disease by identifying appropriate clinical endpoints and standardizing definitions for these endpoints. This was a multi-stakeholder consortium that involved not only physicians and clinicians, but also industry and the FDA. And so these are consensus documents that ended up defining bioprosthetic valve dysfunction by the stages of the morphologic abnormality of stage 1, and then stage 2 and stage 3 as changes in the mean gradient, effective orifice area, and Doppler velocity index. Because the mean gradient is so dependent on flow, we wanted to add the EOA and Doppler velocity index, which are relatively flow independent. And it is the flow changes and absolute measurement changes that are important, remembering that it's not just about hemodynamics, but it's about the valve appearance as well, and then the change in the flow dependent and flow independent measures that should be used. Thanks for your attention.
Thank you so much, Becky. I think this was a wonderful and very clear presentation, really summarizing one of the key points or some of the key points when we really do this assessment of our transcatheter heart valve. So my understanding and my takeaways from your presentation is that we should really consider each transcatheter heart design valve separately. We cannot mix them up in terms of their echocardiographic hemodynamics. And it's also all about relative changes rather than absolute numbers of EOA, gradients, etc. So let me ask you one thing. Is this something that is kind of a class effect? So should we consider this equally for all intra-annular design valves compared to self-expanding supra-annular valve designs, or should we even, distinguish amongst those different devices?
Yeah, I think because each of even the supra-annular devices are designed a little bit differently, and they have slightly shorter stent frames, et cetera, and that we likely, and even the surgical valves are very different, because remember, we have a surgical sewing ring that changes the proximal flow convergence again, even compared to the TAVR valve. So I think that that we will probably likely have to understand each of the valve designs differently. We may have some class effects with the shorter stented valves, and we may have some class effects with the longer stented valves. But again, the difference in stent frame, stent height, etc., may end up dictating further differences. And so I think we need to be a little cautious in using a class effect for all of the valves. So balloon expandable, for instance, are not going to be the same as surgical valves.
Thanks. So you've also dwelt on the fact that invasive gradients, at least immediately after procedure, are very important, obviously. But we can't use it for longitudinal assessment of our, transcatheter heart valve patients. So do you think invasive gradients should be measured? Because I know, and that also goes to maybe Simon and Kentaro, I would like to know their opinion. Is this something we should do? Because many centers actually skip this step, not to measure final gradients after valve implantation in light of the minimalistic approach. But I think that's something that may be very important. So maybe I would like to hear your opinion, Becky, first, and then Simon and Kentaro.
Yeah, I think we don't routinely, but we frequently will measure the gradient immediately after. And it's just very, very common that the gradients are lower by cath than they are by echo. But I do think, in light of some of the information that we now know about those differences that between the valve types, that it might be worth relooking at that as a more standardized procedure, so that we, as clinicians, understand those differences and we don't worry, for instance, about a gradient that may be in your case, Simon, it was 7, but on CAP, on invasive, it might be as low as 2 or 3. And so we don't worry about that gradient. But I do think that echo, because we're going to be comparing the echocardiograms, that the important thing there is to not just measure gradient, but also to measure valve area and DVI.
Simon?
Yeah, I would echo that. With balloon expandable, we never used to measure invasive gradients, but now we're recognizing the importance of it. And so we're increasingly using it, and then using that and comparing it with the immediate post-procedure echo so that we have a baseline of both. And I think it's now, I mean, Becky's shown it beautifully, it's becoming increasingly important.
Kentaro, finally?
Yep. So actually, I always measure the invasive measurements just after procedure because in our country we have a lot of patients with very small anatomy. So I think it's quite important to measure not only echo but also the invasive measurement. We can take into account our measurement for the follow-up.
Thanks to you all. Maybe one final question going back to Becky. What we've seen is especially, for smaller balloon expandable valves in the data you've shown, there seems to be an even higher discrepancy between invasive and echo gradients. Can you elaborate a little bit on this, why this might be the case? Is it specific to the measurements that you perform by echo, the gradients you derive, or how do we explain this difference, especially in smaller valves?
Yeah, I think it's possibly and probably related to pressure recovery. So we know that the smaller aortas and the smaller ratio between the valve area and the aorta, so a more tubular type structure, is going to end up having more pressure recovery. And so that's why I believe that the smaller valves end up having more pressure recovery and therefore a greater difference between the echo measured gradient and the CAP measured gradient. And I think that's something important to remember as we start to look at, outcomes of these patients. We've still, haven't been able to, at least in the balloon expandable valve, see a difference in outcomes based on gradients. And I think in part it's related to the construct that allows for greater pressure recovery.
Thanks. That's a very helpful explanation. And I think we should even emphasize once more, that obviously all these differences and subtle changes were embraced in VARC-3. And we cannot stress enough how important it is to really consistently use these definitions amongst clinical trialists. And because otherwise it will be obviously impossible to really compare things appropriately. What's your opinion on that, Becky?
I agree with you wholeheartedly. I think that, we were very thoughtful about the definitions and the reason why we used percent change, and it was all supported by data. And I think that using the VARC document and having already some evidence that those types of, looking at changes in function rather than absolute gradients is important in determining outcomes. And so I couldn't agree with you more. I don't disagree that we need to continue to test those criteria, but I do think that we should attempt as a community to use the standardized definitions in studies of outcomes and durability.
All right, thanks so much. I think this is a very interesting discussion. We could probably go on forever in disputing this and discussing this, but I guess it's time now to move on to Kentaro Hayashida, who will put this into perspective by showing real life and real world data, clinical outcomes, and performance of latest transcatheter bioprosthesis. Kentaro, please take it away.
Thank you very much, Michael. And actually today I'm going to talk about our latest data and experience about S3UR in our country. And actually, we're organizing Ocean SCT family, which includes 29 very active centers in our country. And we also include the data from the TAVI cases, mitral tear case, tricuspid procedure, and appendage closure. Until the end of last year, so we have already enrolled more than 22,000 TAVR case and 4,000 mitral case from all over Japan. And we're quite happy to launch the S3UR from the March 2023. And we try to publish the data from our OSHA Institute family. And we compared S3UR and S3 using propensity matched analysis. And finally, we compared the 600 S3UR and 600 S3 cases. And the primary endpoint was the valve performance of the each valve. And as you can see, we have significantly lower incidence of the severe prosthesis patient mismatch. And the S3UR has the only 0.5% of the severe prosthesis patient mismatch. That is significantly lower than that of the S3 of the 2%. And the incidence of the mild or greater PBL was decreased, as well as the incidence of the mean pressure gradient more than 20 was also decreased with S3UR compared to S3. And this study was conducted by my good friend Masanori Yamamoto from Toyohashi Heart Center, and who is in charge of most of the scientific part of Ocean Institute family. And if we look at the data, and the effective orifice area was significantly larger with S3UR compared to S3. And the mean pressure gradient was only noted in 9 millimeter mercury with S3UR. That is significantly lower than that of the S3. And if you look at the incidence of moderate PPM, and 8.2% of moderate PPM was noted in 20 millimeter sapien UR. That is quite relevant. That is quite equivalent to that of the incidence of moderate PPM of the 29 millimeter sapien 3. That is quite surprising data to us. And notably, the severe prosthesis patient mismatch was not noted in 20 millimeter sapien 3 UR. However, we saw the 6.6% of the severe prosthesis patient mismatch with sapien 3. And this significant reduction of the incidence of severe prosthesis mismatch in moderate PPM was observed in not only 20 or 23 millimeter valve, but also in 26 and 29 millimeter valve. And the reason for this reduction was presumably partly due to the way of sewing, and partly due to the material of the residual tissue itself. And in conclusions, S3UR was associated with better hemodynamic performance compared to S3 in all size variation. And notably, severe PPM was noted in only 0% and 0.9% with 20 and 23 millimeter S3UR valve respectively. And PBL mild or more than mild was significantly reduced with S3UR. And S3UR provides better hemodynamic performance and reduced PBL over S3, even in patients with small annulus inner country. And thank you very much for your attention.
Thank you very much, Kintaro. I think you have to be congratulated for providing this data, for doing the Ocean TAVI registry, and really taking the effort really to carefully assess this. And there's very little real-world data on this new device that is on the market. Some part of it comes from the United States, the other from Japan. So in Europe, we've just started. I can say we are excited, but not that far advanced. But this is very exciting new data. So something that I would like to ask you, what is obvious to all of us, is that there is a huge improvement in terms of gradients, but also in terms of patient prosthesis mismatch. Now, is this something you believe that is especially relevant to the Japanese population, or maybe can be translated to the entire Asian population because of smaller body sizes? What's your thought on that?
Thank you very much, Michael. And actually, the S3UR was associated with the much decreased incidence of severe PPM compared to S3, and that is due to the material or way of sewing. Especially in our Asian cohort, we have a lot of patients with very small aortic annulus, and that result is quite relevant to not only Japanese but also for all the Asian cohort who has the smaller body size compared to Western people.
Okay, thank you. And then patient prosthesis mismatch. This is something that is sometimes I personally find very difficult to assess because it's based again on echocardiographic measurements. And we know they can be prone to errors actually. Now in your study, how was this done? Was this assessed centrally in a core lab or was this done at each individual site?
Okay, so actually this is not called adjudicated analysis, but we found that the older center reported the quite same result, quite similar result, that the S3UR is much better than S3. That we convinced that that is quite reproducible result because the older center reported a similar result in our registry.
All right, thank you. Well, let's discuss this maybe amongst, the three experts that we have online today. So compelling data with regards to improved hemodynamics. I would like, to hear your opinion also. Let's say, if we have a patient that comes in, receives a valve, what should be the optimal techniques to follow up on our patients? And again, also, how do we assess for patient prosthesis mismatch? Should this be done invasively in the cath lab already? Should we do echocardiography immediately after the cath lab? We often have a discrepancy also the day after the cath actually, because the patient may be on different hemodynamics, different flow and fluid conditions. What are your standard ways to assess, these valves longitudinally? Maybe we start with Becky and then Simon again and Kentaro.
Yeah, I mean, we obviously use echocardiography. We understand, and we all understand that there's a difference now between the echo and the cath gradient immediately after the valve. But the studies have continued to show that as the valve becomes dysfunctional and stenotic, that the cath and the echo gradients become very correlative. There's not much difference in the gradients. And that's again because of that first slide that I showed about turbulent flow and how now cath and echo are measuring the same thing because of the turbulent flow. And so echocardiography for me remains the main method of assessing valve function, remembering that it's not just about the gradient. So we would typically, let's say a patient comes in with a high gradient, we will immediately try to look at their baseline discharge or 30-day echo to see, one, if the gradient is the same, in which case we don't worry too much, and two, whether or not the calculated valve area is the same. Now, and on DVI, and if the patient's gradient is higher, we again then go to EOA, effective orifice area, and DVI. And if the EOA and DVI are not changed, then it has to be an increase in stroke volume that accounts for the increase in gradient. And so again, we're not worried and we don't go to cath. When we use catheterization is when we believe there's a significant enough increase and that we're concerned about real dysfunction, and we may go to cath. In all honesty, we will also do CT scan to look at the morphology of the valve if we've had difficulty, or a TEE to again confirm that the morphology of the valve is correlating with a change in the hemodynamics. And that's in our routine. We frequently get patients coming in from their referring physician saying the gradients are, as high as 12 and it can't be normal, but the valve area is 2 centimeters squared. And then we just reassure everybody and we don't worry about it.
Thanks. Simon?
Yeah, so as I mentioned earlier, we're increasingly measuring invasive gradients at the time of the procedure. We tend not to do the echo on the same day. We do it on the morning after the procedure, unless in the very rare occurrence, it's a day case procedure, which is not common for us. So typically it's the following morning. And the reason for doing the invasive gradient is really so we can learn more about this disparity between invasive gradients and echo-derived gradients. And then at follow-up, if the gradient has significantly increased, usually we will go to get a multi-phase CT to look at the valve morphology and the leaflet morphology, the thickness and the motion of the valve leaflets to make a decision as to how best to take things forward. Thankfully, it's not a common occurrence, but that is our current sort of protocol.
Yeah. Kentaro, what's your standard procedure of following up these patients?
Yep. That we usually perform the invasive measurement at the procedure, and we usually perform the echo assessment one day after procedure, and we take into account the data from the invasive measurements to watch the patient. And the follow-up is usually performed by a transthoracic echo. If we see some increase in terms of the gradient, we usually perform the CT scan to see the leaflet motion. And if we see some doubt, maybe we can think about transesophageal echo. But in general, so the patient never come back because of not only because of the some increase of the mean pressure gradient, and we also need to take into account the symptom or BNP level or other indices to diagnose the patient that the valve is really failed or not.
Thank you, Kentaro. I think this is really interesting. And maybe I have, because really we have the experts here, we have to dwell on this a little bit. And so on the one hand, we learned today from Becky's presentation also that each valve should be judged separately. We can't directly compare echocardiographic measurements because this is based on a lot of physical principles. On the other hand, we learn now from Kentaro and from Simon that obviously there seems to be a difference in SAPIEN 3 Ultra and SAPIEN 3 Ultra Resilia in terms of gradients and its hemodynamic performance with lower gradients, less ppm. So I would like to know from you, how important do you think this is? And Becky, maybe especially to you, how can we explain this? Is this just simply due to the way that the leaflets are sutured, which obviously we've seen that there seems to be a lower profile, and also the opening of the leaflets seems to end in a larger effective orifice area? Is this the explanation, or is there something more to learn?
I think that is the main explanation is that the orifice area is indeed larger. There have been a number of iterations, as you know, of the valve. From the XT to the SAPIEN 3, they added that suture to the SAPIEN 3. And when you look at the normative data paper, there's very slight differences in valve area. It's a little bit smaller for the SAPIEN 3. Again, probably because the suture was added. And now that the suture has been changed and the leaflets are opening more fully, I do think that the valve areas and therefore ppm is reduced. But one of the other things you have to remember about ppm and valve areas is that with a balloon expandable valve, the valve will expand to the size of the annulus, and the annulus we know is directly related to body size. And so in effect, these balloon expandable valves, which will expand all the way out to a native annulus, kind of normalize then for the patient's body size, because they'll expand to the appropriate size of an annulus for that body size. And that's why I think, in designing a valve that also allows the flow to look, so laminar and the leaflet so columnar, you're going to reduce the prosthesis patient mismatch. So I do think it's the way that they've changed the leaflet configuration, and perhaps the leaflet, the Resilia tissue as well.
Thanks, Becky, for this additional explanation, which helps a lot. Simon, what's your opinion on Resilia itself? So obviously, this is a specific way of tissue preservation that, enables much slower process of calcification. That's what we've learned about Resilia. How important is this to our patient?
Well, I think it's crucial. And, the major limitation of TAVI when we're speaking to patients is durability. That's what they're worried about. And that's important, particularly as we move to younger patients who are going to have a longer life expectancy. So it's absolutely crucial, and it's central to our decision making of TAVI versus AVR. As we're moving to younger patients. So is probably the most important factor in my mind. We need to choose the best valve, which is going to have the longest durability and the least chance of having to have a repeat valve-in-valve procedure. So, there are several design iterations of the Resilia, which we've discussed over the last hour, which have shown, dramatic improvements, which hopefully, both in the short term and long term, will reduce the risk of the patient needing a second procedure.
Yeah, I couldn't agree more. I think that is extremely important. So the point is also, I guess we've learned just recently, or we are starting to learn that, TAV and TAV procedures can actually become quite complex procedures. We have to talk about other topics which we haven't covered today, things like coronary protection to protect from coronary acute obstruction, but also coronary future access, things like this. And I believe that these procedures in some of our patients can become quite complex, and we shouldn't be too liberal in implanting, new valves in and not, thinking about their durability and sustainability. So maybe, Kentaro, one question to you finally, is this something, that you would consider also, especially for younger patients only? Would you reserve this for younger patients? Because we've seen a very interesting and I think intriguing case from Simon today that this is something that affects maybe not only the young patients that we will treat in the future, but even a 80-year-old is not willing to have a second procedure in her life. So what's your thought on that?
So thank you very much, Michael. And actually, considering the second procedure is quite important, especially in our country that they have the longer life expectancy. Even 85 years patient, that they might come back 8 years and 10 years after the procedure. I think that the repeatability of the procedure is quite important. That means that if we can do TAV in TAV or TAV in TAV in the future, is quite important. So we need to tailor-make the plan, the lifetime management plan, if we perform the index procedure when the patient came first to us. That is my opinion.
All right, thank you very much. I think this has been a very exciting discussion. And again, we could go on and go on. I think it's time to maybe wrap up and summarize this hour of lively discussion. I think we've seen a very exciting case by Simon Redwood, who showed us that, this can be even more simplified, the procedure, by doing single access. And I'm really thrilled to see this, Simon. And I'm looking forward, more centers performing this kind of procedure in the future. Maybe for now, it's easier to learn with balloon expandable valves, obviously, because you don't need a landmark during the entirety of the procedure. We've seen and we've heard an outstanding presentation by Becky Hahn, who really taught us what we have to look for, and maybe also explaining why we have to be careful in directly comparing hemodynamics amongst different valve types. I think we've also learned that it is to standardize our definitions, which we use to assess these valves longitudinally, but also especially amongst clinical trials. I think these important differences were embraced in VARC 3 definitions, and I think there should be no reason why not to really use these definitions for future clinical trials to really compare different valve types, but also to compare one valve type longitudinally. And then finally, we've seen the outstanding outcome of a new generation device, the SAPIEN Ultra Resilia by Kentaro Hayashida, who showed us exciting outcomes, lower gradients, lower ppm, especially in the smaller annuli valves, 20 millimeter valves, which is really promising. No doubt, I think we can all agree that we need to carefully assess this in prospective randomized trials to make sure that this really, this valve type and this Resilia tissue is holding its promises. I'm sure it will, but we'll need to do our homework, of course, in the future. With that, I'm almost done. I would like to thank the audience for raising important questions, for engaging with us. I would like to thank the speakers, outstanding contributions, and stay tuned for the upcoming series of PCR webinars. Thank you so much to you all.